Thank you. The title is almost impossible or very easy. What is unique? I don't know at all. But I will use the last 10 minutes to say some new stuff. This is not new stuff, and is the story of two patients that I show every time. Sorry, but I also don't see anything. Luca and Simone. Luca has a livedo-reticularis fever and then an hemorrhagic stroke. He has a classical manifestation of panarteritis, good response to thalidomide, and when he withdraw the drug, have a second stroke, and he also had hypoglobulinemia. And Simone have a similar history, livedo-reticularis, panarteritis with the intestinal involvement and the stroke. And Simone and Luca were brothers. So when Ivona tested the patient for the first time, she sent these two patients with this combined heterozygous new mutation coming from Italy, and also a third patient that was a patient with a similar phenotype with this new, at that time, new variant that was that is a T368 mutation that seems to be really the Italian mutation. When we start making let's say, survey on the Italian case of the DADA2, that was the situation of the different variant that has been described until April 2016 in the literature. There are, as you know, some a variant that is really frequent in Turkish patient and also in Georgian Jewish patient, and this is the typical Dutch variant that has been described in the Netherlands. I already showed you the Italian cohort two years ago, but I would like to show you some new stuff related to this cohort. We use a homemade enzymatic activity on the monocytes, and we test, of course, inosine and epoxanthine concentration after inhibition with DADA1 inhibitors on supernatants of activated monocytes. It's a different test, but it's very reliable. These are all the families that we studied with all the different mutation, new mutation, and as you can see here, in Italy, indeed, this mutation is rather frequent. 46 of allele involved, 46% of allele involved was this. And the clinical feature is more or less, I think, similar to those that Seza will see in Turkish papers or Jakov in the Israeli and the others in the Israeli population. I'm a little bit intrigued by the high percentage of acute hearing loss that we observe in our cohort. Interestingly enough, all these patients have the Italian mutation. I don't know if there is any correlation, but this is something that scared me a lot. Last time, and in the paper, there was this family in which there was some really positive patient in terms of clinical activity, livedo-reticularis, stroke, and so on, and they were heterozygous. You can see here like the father. And we describe they have a clear-cut alterated enzymatic activity. We search a lot, a possible other explanation, loss of heterozygosity, analyzing the cDNA, deletion or duplication were excluded by Ivona with MLAP-A, and also we look for other genes, but at a certain point, these two patients, when the family entered in a novel NGS panel for strokes that we have in Genoa now, and the second mutation was found. Indeed, they were not heterozygous, but we found, and the explanation from our geneticist Isabella Ciccarini, that in the supposed wild-type allele, there was a polymorphism in the region where the reverse primer binds, and so there was a decreased affinity of and amplification of wild-type allele, the true wild-type allele, where the polymorphism is not present with a higher affinity. That was the reason why Sanger was not able to identify And so this is important also for this patient that we described in the paper was a completely negative patient from Sardinia. Maybe you remember last time I showed this patient that have fever, livedo reticularis, myocarditis, three events of strokes, and again low level of IgG. And she was completely negative. She had an enzymatic test that was positive, and also we sent also the sample to Mike, and the plasma was, the activity was very, very low in this patient. You know that our gene is on chromosome 22q11, and this is very important because it's an unstable region that is subject to copy number variation in terms of possible deletion and duplication. So we perform with our geneticists the whole genome sequences, and what happens that we found in this patient an homozygous tandem duplication of a genomic region that encompasses exon 3 and exon 4, and that give rise to a huge deletion of the protein, and that is the reason why this patient is so positive at the genetic test. And we have a similar experience also in two twins that are now followed by our colleague in Milan, two twins that have a classical phenotype. They were sent to us to make the functional analysis in Genoa, and was absolutely positive. They was heterozygous, and the father was heterozygous too, but they have the classical phenotype. One of them has been transplanted by our friends in Milan, and then in parallel, both Ivona and our friends found a deletion in these two girls. That means that we have to look after this and to look for the possible other mutation, and sometimes it's not that easy to find, but we have to search for that. This is another patient that is from Guatemala. She's adopted, and she had the classical phenotype, and unfortunately also the classical delay of diagnosis. This is very, very, I mean, we saw Lucia this year. She had the 2 episodes, important, and she had a good response to umbrella as soon as we saw the patient, and we showed the reduced enzymatic activity, and we start, of course, as Tanner said before, having the result of genetic test that was positive for the classical Georgian mutation in the patient from Guatemala. And I think it's an expander idea, idea on the possible location of the different mutation around the world. I will show also this very strange patient that we saw in the past, I have to say, because is again an adopted patient from Vietnam. She had this strange episode of recurrent fever with skin rash and arthralgia. She has a susceptibility to viral infection, rather impressive, I have to say. 2 episodes of MAS with a possible trigger with a viral, and one was associated to sterile in sort of sterile encephalitis. You have a full immunological workup that was completely normal. Just as you can see, a slight decrease of IgG levels. And she had a good response to steroid for the fever episode, but no response to anakinra. And we start to use for her IgIV that was very effective every month, were very effective to block the fever episodes. So we sent it to Borzug lab, to NGS, that was a huge panel from many immunodeficiencies, because we thought for this viral infection. And what we observed, there are 2 interesting mutations in homozygous manner. One is for DADA2. This is unknown, but possibly pathogenic mutation, and that is very interesting, is IRAK1. We are not able to find so far the possible idea, so maybe Gigi can help us to identify the possible role. But however, what we know is that also for Anna Tau, the enzymatic test was completely positive, and also we send it again to Mike, and the same came in his lab. So she had this strange phenotype, but she's still going very, very well with IgAV. I don't know if this, for sure, for the inflammatory phenotype, they are very, they're very, very effective. The patient don't want to go into anti-TNF treatment, and so far we were treating. So that's why I was not one of the doctors that sign IV as a possible treatment for acute, but maybe that could be logical. And after this experience, maybe I would use IgG in an acute phase. Could be useful. So this after many other paper, now I'm very close to chip moment, so I have to be quick. You can see here other mutation, and some can be seen in different ethnicity, and so I mean there is not a complete dissection of what we can observe. We have observed also one of these mutations in heterozygous in an Italian patient, and also in the patient from Guatemala. And so we will see also if there are differences between the different genotypes, ethnicity, response to treatment, and so on. Complication, we still don't know. It's something that we have to study. Even the hematological phenotype, as Ivona pointed out, is not. It do not seems to be any differences between patients because one cohort is from Israel and the other from other European country. So I think that, again, I come on this point because I think it's very important that we need an international longitudinal registry of DADA2. I think it's very important for all rare disease, as we know. We need information of the clinical manifestation, genotype-phenotype correlation, efficacy, and the safety of the treatment in the long run. And also, it will be important to compare DADA2 with other different inflammatory conditions to make recommendation, evidence-based classification criteria, and so on. As you know, we are more really great fan of Eurofever that collect a number of different autoinflammatory disease, more than 4,000 patients around the world. And this is very detailed registry that is indeed for all the autoinflammatory disease, in which we are able to identify very dissect all the clinical now is the chip all the clinical manifestation in very detailed way. And together with Paul Brogan, we adapted the longitudinal part of Eurofever also for DADA2, and so that will be for sure more related also to these conditions for the new. And the utility came also from this work, thanks to the work of some of our residents. We were able to give a picture of the genotype-phenotype correlation of the most relevant diseases, CAPS, TRAPS, FMF, and hyper-IgD in this publication, in which we were able to describe for all the mutation that were observed in the Eurofever registry, which was the phenotype of the patient, the complication, the response to treatment, and that could be useful if you have a patient go to the paper or to the Eurofever registry to see. So I think this is something that could be very useful also to follow the patient and to make the longitudinal response to the treatment and also the complication of the treatment and adverse event. So in conclusion, DADA2, we have to understand if genetically incomplete DADA2 patient exists. I think that if you have typical phenotype with an incomplete genotype, do the functional test and treat it. If it's defective, then you have time to look for the missing mutation. There is a huge clinical variability and severity of DADA2, we now know. We need more information on genotype-phenotype correlation, data on treatment in the long run. Of course, this is, I skipped the acknowledgement, but in the last 10 seconds, I would like to ask you to come to the next meeting of International Society of Autoinflammatory Disease. That is a biannual meeting, very interesting, on all autoinflammatory disease that will be held in Genoa, my town, in March, April 2019. Thank you very much.